Good morning, everybody. We welcome you all for this panel discussion today. My name is Vinod, and I will be the moderator for this event today. This discussion is largely going to be around urban marginality and resilience expectations. And most of our panelists will share experience from working with deficits in the urban informal delivery of services and accesses. We bring this presentation to you and this panel to you largely from ARISE, which is an action research project that looks at accountability particularly in health and well-being of urban marginalized populations. The session is also brought to you by SPARC. We are an NGO based in India, committed to supporting movement of network of slum dwellers called National Slum Dwellers Federation and women's collectives called Mahila Milan. I will just give you a brief introduction of what to look forward to in the panel presentations, and then a discussion after that today. So we will touch upon the intersection of marginality and resilience in the context of urban informality largely. We know that globally, we are having a lot of people who are living in the urban areas in informal conditions, living and working in informal conditions. And many of the actions that they take are based on the choices that are accorded to them. And many of the actions that they take are largely survival strategies. But do we have a danger that those survival strategies are sometimes being considered as, or rather romanticized as being, self-reliant or self-resilient behavior? And so can we call those actions as being resilient? Now, for example, we know that in the recent pandemic, there was a very large-scale disruption, and the people who were disproportionately affected economically largely were those who already were in poverty in the urban areas. And what we saw was that there was a further increase in the number of people that went back to being poor because of loss of livelihoods and many different disruptions. But what we see now is things inching back to normal, and we see a lot of people trying to inch back to normal. And when that happens, then again, there is a danger of considering that as being resilient behavior. And we know that in many of the cities in the global south, we did see lesser than satisfactory response by the duty bearers, largely the governments. And so in that situation, if people can bounce back, then will that be considered as being self-reliant and resilient? We also know that many of the cities in global south do have poor public health access. And there is like a silent shift towards privatized healthcare provision and neglect of both quantity and quality of public health services. And now, in spite of that, we see people surviving. But then again, those are survival strategies. Now, can we consider those as being resilient? So, but the other questions that I have, and I hope the panelists will get answers to these from the panelists, that are there elements of adaptation that can make are there elements of consideration that can make adaptations more inclusive? For example, should we move around only acknowledging the precarity of livelihoods of those working in the informal sector, or we also look at the intersection of livelihoods to other set of policies and other set of issues that they anyway face because of their marginalized situations? Is it important to consider that when we consider adaptation, local adaptation? And as we saw on the previous slide, people supported each other, developed their own set of survival strategies. While there's a danger in romanticizing them, there is a need to acknowledge that that there is some element of possibility or some element of people's ability to fight and be resilient, but it requires processes. So the first step to that would be acknowledging what those people's processes are. And the second step would be to look at how that can be supported so that people make informed choices and not just make choices because that's the only choice that's available to them. Is there a need to look at public healthcare, especially in the aftermath of COVID? Where we saw that having had universal public healthcare would have averted much more of serious illnesses and deaths we ultimately saw in the times of COVID. And also, it links with the ability of people to be resilient. And lastly, if people's needs and aspirations should be central to urban planning. I mean, urban planning does consider the need for things like housing and access to basic services, etc. But does it really take people's needs and aspirations central to it? And what I mean by that, for example, is we can have an adaptation plan which says that people who live on the floodplains are specifically vulnerable to being, that the house is being destroyed by floods, etc. So a policy response could be doing housing for people who live on the floodplains. But if you don't have a policy feature which says that irrespective of your tenure status, you will be entitled for housing so that you can live in protected habitats, the plans will fall through. So there are some of these underlying nuances of urban policies that do not necessarily link to the urban planning, and we do end up having adaptation plans that does not necessarily address the very core needs. So I am only hoping that some of these questions will become clear as we wait through our panel discussion and as we wait through our panelist presentation and later the discussion that we will have. So I will speak only that much, and we will know more. We will hear more from our panelists today. We have 4 panels today. One, the first would be Shrutika Murthy and Inayat Kakar from the George Institute for Global Health, who have been working with waste pickers in Indian cities. They're colleagues from ARISE, and their experience and understanding the lives of waste pickers, both in terms of habitat as well as livelihoods, it has some lessons for us and perhaps some answers to questions that I've asked before. And Wafa Alam from Bragg James P. Grant School of Public Health has experience working with slum residents in Dhaka, and she'll largely be presenting around the engagement and the study and the relief work, etc., that the school has had with the slum residents in Dhaka, particularly during COVID and lockdowns. And it definitely does touch upon some of the questions that I have asked. Dr. Aditya Pradyumna teaches at the Azim Premji University, and he and some of his colleagues have recently published Healthcare Equity in Urban India, published a work that traces healthcare inequities in the urban areas. And there are a lot of lessons for us to look at the interaction between public health and adaptation and climate change. We hope from the presentation that will also answer some of those resilience questions that I asked. The last presentation would be on what is a special planning area and how it links with an urban development plan and what constitutes an inclusive special planning area. Unfortunately, Smriti Jukur from SPARC, who was to present this, is doing very unwell today. But since I've been associated with that project to some extent, I'll try to present it to the best of my capacity. If you would like to know more about us, there are some links to SPARC as the NGO, the ARISE project. And if you want to know more about the session's background, there are links to that as well. And my colleague Maria will put this out in the chat box if you would like to go and see that. With that, I will end my presentation, and will request the first panelist to come forward and start the presentation. So the first panelists are Shrutika Murthy and Inayat Kakar, who will be jointly presenting the session. Welcome, Shrutika and Inayat, and over to you.
Good morning, everyone. Inayat and I are delighted to be here on behalf of the ARISE Hub at the George Institute for Global Health. So in today's session, we'll be sharing about the experiences of waste workers in urban marginality and resilience and climate change as well. So at the George Institute, the ARISE Hub works with waste workers across 4 cities of India. The first one, as you can see on the left, is Shimla, Himachal Pradesh, which is located in the Himalayas. So it's located in the mountainous region of the country. And here we work with contractual door-to-door garbage collectors and tenured sanitation workers. Um, in the second picture that you see here, we work with waste pickers in the informal sector in the cities of Guntur and Vijayawada, which is located in the state of Andhra Pradesh in the southern part of the country. And what you see on the right is a picture of a waste picker again in the informal sector, but located in Bangalore, which is located in Karnataka in the southern part of the country. But here the waste pickers also run dry waste collection centers and are slowly being integrated into the city's municipal solid waste management systems. Um, so as a geographic snapshot, I thought I would kind of show you in terms of where all of our action sites are located. So as you can see, Shimla is located in the northern part of the country, close to the Himalayas, and Bangalore, as you can see, is on the western coast of India, and Guntur and Vijayawada are on the eastern coast. So all of these action sites have very different geographical terrains and climatic conditions, which makes the work of waste work very different, and the way that it's carried out and the environment in which they're located. So today we'll be sharing about the experiences of waste workers in 3 cities. So one is Shimla, the second is Guntur and Vijayawada. So I will be starting this presentation by sharing about the life, work, and environment of waste pickers that are located in Guntur and Vijayawada. So here in Guntur and Vijayawada, we work with waste pickers in the informal sector, who are more commonly referred to as rag pickers. And what they do is that they collect, they segregate, and they sell discarded materials, especially recyclables, to earn and make a living. And in our context, where we're located, the Indian laws don't recognize their work as an occupation, and they're often perceived as thieves, and a vagrant part of society. So as you can see in the presentation here, there are pictures that you see on the left. So one is a cycle, and with a board attached to it at the back. So the waste pickers here, they cycle and they walk around different parts of the city and try to collect recyclables. So they start their day as early as 2:30 or 3 o'clock in the morning, and they walk and cycle distances on a radius of up to 15 to 20 kilometers for many hours at a stretch until they've collected enough recyclables. And the climate of Guntur and Vijayawada is tropical, which means that the temperatures here are really, really hot. As a result of climate change and otherwise, the temperatures in these cities has just been increasing. And it's been recorded that the highest temperature during the summer months here range between 45 to 50 degree Celsius. So you can just imagine that the kind of work that they do, the nature of its work is also very difficult, as you can see in the picture here. where they're trying to identify recyclables through mixed waste without using any kind of protection or protective gear whatsoever. And here, when we're working with waste pickers in the informal sector, they're very fragmented segments throughout the city. So you don't have an entire settlement of just waste pickers. You have households of about, I think, 20 individuals that are spread across the city. And we also work with waste pickers who actually live and work on landfill or dumping grounds as well. So, in that sense, their work and life environment is pretty much the same. There's not as much of a distinction between a home and a workplace for some of these workers. And you can see in the picture that's on the bottom right, they also live under flyovers. And these cities also deal with issues of droughts and floods during monsoons, which makes their living condition very precarious. So if there is ever an incident of a flood, they're bound to be the worst affected communities, but they're also the least served by duty bearers because they don't figure in their list of priorities. So I just wanted to go ahead to discussing some of the health and well-being issues of waste pickers in the informal sector. So the perception of waste pickers that we've grown to understand in recent scholarship, as well as in debates and articulations of policy, is that they are not recognized as workers. Their work is actually not considered to be work. They don't consider their contribution to the city's safety, hygiene, the environmental contribution. And so there is now a recent discourse around trying to recognize them as workers and changing the perception that exists towards waste pickers. And I think, as you've seen in the pictures previously, and as you can see now, their living and working conditions are very precarious, and it's underlined with the hazardous nature of their work and the toxicity that it involves in terms of not just picking up and dealing with the discarded materials, but also waste pickers who work on landfill sites, the fumes that they inhale, and the environment in which they work in is extremely toxic, and which naturally has an impact on their life expectancy. So, for example, we work with a set of waste pickers on the Guntur dumping ground, and since the past 3 years that we've worked there, we've actually not found any waste picker there who has lived beyond 50. So, I mean, the kind of nature of their work naturally decreases their life expectancy very significantly. And these sections of population experience many and multi layered instances of discrimination, not just from the state, but also from the society and health systems. There have been many recorded cases of them being disrespected at health institutions. Which makes them very skeptical of going to institutions to seek care. They're not respected by the state and society at all, and they experience different forms of violence, including structural violence from the state and society both. Then you obviously have the gendered experiences of care in the way that the women access and experience care at healthcare institutions as opposed to men. And what we also have to understand is that the work of waste work in India um, is carried out and done by historically oppressed communities, which is laden by, I think, the gender, their occupation, the caste that they belong to, the socioeconomic category that they come from, and all of that shapes that the way that they receive and receive care at healthcare institutions. Now, the health system in these spaces is again very fragmented because the way that the waste pickers are spread across throughout the city makes them very distant from healthcare providers as well. So the role of the state in ensuring availability and access to comprehensive care is possibly the least for these communities because they don't figure in their list of priority at all. There is a lack of primary healthcare centers in these cities, so their reliance on secondary and tertiary care facilities is a lot more, especially private health providers, which leads to a lot of out of pocket expenditure for them. They also experience a lot of challenges in accessing social security benefits which they are entitled to. And COVID-19 has only made all of these vulnerabilities worse. So it's not that COVID-19 kind of got in these vulnerabilities. They've always existed. It's just that something like the pandemic and a lot of climate change related incidents just kind of exacerbate these vulnerabilities. And these communities are extremely reliant on civil society organizations and philanthropists to fix that gap between what they're actually entitled to and what they can access. And I think in relation to climate change, what we'd like to also communicate is that there is a lot of debate and discourse around the way that waste workers contribute to the environment and how they're contributing to the environmental sustainability by segregating waste, they're reducing greenhouse gas emissions and all of that. But there is very little discussion around how climate change in itself um, impacts precarious segments of society like this. Like, how is it that they deal and cope with climate change incidents? So that's something that we want to put forth through this panel. And my colleague Inayat will now take over from me and talk to you about the life, work, and environment of waste workers in Shimla, and what are the health and well-being issues that they face. So thank you so much for your time.
Good morning, everyone, and thank you, Shrutika. Thank you. Right. So I'll be talking about the life, work, and environment in Shimla. So in Shimla, we work with door-to-door garbage collectors. These and in Shimla, there are tenured workers who are directly employed by the municipal corporation for actions like sweeping, etc. But the door-to-door garbage collection work has been informalized by the creation of a society by the municipal corporation itself, and therefore it's sort of been outsourced to the society, and the workers are then contracted through this society. So what was an occupation which was integrated into the municipal corporation has now been informalized. As you can see in the photographs, and as Shrutika had mentioned, that Shimla is, a mountainous terrain, and therefore, it's not flat. So there are a lot of steps that waste workers have to climb. In certain colonies, there are not even these proper, this infrastructure in terms of stairs that exists, and so they have to walk through, the mountainside. And as you can, and when Shrutika and I had shadowed some of the waste workers, we found that on average they walk anything between 10 to 12,000 steps. And again, I'd like to reiterate that this is not on flat terrain. This is on a mountainous terrain, which again has implications for their health and their well-being. And they usually carry anything from about 20 to 25 kilos of waste on their back. As you can see on the photograph on the top left, there's a woman waste picker who is carrying, the waste on her back. There's lack of implementation of waste segregation in Shimla, which means that residents will end up providing mixed waste, so dry and wet waste together. And as you can see again on the photograph in the top left, she's wearing a plastic sheet to prevent the leakage from the waste, contaminating her body. So they do wet and dry waste collection together. There are bags for waste collection that are provided by the municipal corporation. However, in terms of quality and quantity, these are not sufficient. So as you can see here, they are using bags which they source from shopkeepers, or which they often have to collect themselves, and they're not the most suited for carrying both dry and wet waste. In Shimla, the society that has been constituted by the municipal corporation under whom the workers fall is called the Shimla Environment, Heritage, Conservation and Beautification Society. So there is, in some ways, formal recognition of the role that the waste pickers play in maintaining the environment. But at the same time, what is the precarity that they face because of environment and climate change is not something which is central to the municipal corporation. Because Shimla is the capital city of the state of Himachal Pradesh, and tourism is a big part of the economy. The work of the waste pickers is very central to maintaining the city's public health and also the image as a tourist spot. And therefore, and therefore, if the workers are on strike, or if if they're on strike and the waste collection is not happening, then this becomes pretty apparent, and there is some level of political oversight due to this. um, and again, as Shrutika had mentioned, that that waste pickers are very central to ensuring environment safety, and they contribute to climate change by recovery and recycle of waste material. How their lives are impacted by climate change is not something that is a focus. In Himachal Pradesh, there are a lot of landslides, there have been cloudbursts, and often entire settlements end up getting washed away. But again, and since the waste pickers live in in the marginalized bits of Shimla, their housing rights are not something that are priority per se. And recently, it was only after a struggle of about 2 to 3 decades that even right to housing of waste picking communities and sanitation workers were recognized in Shimla. Coming to the temperatures, so because this is a mountainous region situated in the Himalayas, the temperature ranges from anything between 30 degrees Celsius in the summers to minus temperatures in the winters. And often the waste pickers have to plow through snow for doing the door-to-door garbage collection work, and the attire and the protection equipment that they are provided by the municipal corporation is often not suited for walking through rain and snow, and this contributes a lot to them getting injured. Can we move to the next slide? Thank you. So when it comes to health and well-being, first there is, we have a three-tier architecture, three-tier healthcare system in India, where you have the primary healthcare system, then you have secondary healthcare services, and then you have healthcare services at the tertiary level. Now, Shimla, being the capital city, has, a congregation of tertiary level facilities, and therefore there is an over reliance on these tertiary level facilities when it comes to accessing care. And there is more of a focus on on curative care as opposed to preventive and promotive care, which, as you can see by the working conditions of these communities, is very, very essential. Again, the focus tends to be on occupational health. It tends to be disease focused, and the focus on their overall well-being is absent. There is a corporation health officer that is placed within the municipal corporation, and the focus of the corporation health officer is on maintaining hygiene and public public safety as far as health is concerned. But the role of the municipal corporation in ensuring access to healthcare services, or even promotive and preventive care, is missing. And there are no formal mechanisms within the corporation itself to ensure that people are able to access the care that they require. Because the public health system in India and also in Himachal Pradesh is overburdened, and there tend to be long lines. Going to a hospital to access any sort of care often involves, it'll take a whole day for people to be able to meet a doctor and to be able to get the medicines and go through the entire system, which means that people have to give up their daily wage. And this becomes a disincentive for people to access public healthcare facilities, and therefore is actually pushing people towards private providers. There are also disparities in terms of gender when it comes to accessing care. So, for example, one of the waste workers was talking about the experience of her family in accessing healthcare. So, when her husband had a health issue, they went to the private care provider, which required significant out-of-pocket expenditure. But when it comes to her own healthcare, she said, she would not access care, or she would go to the public sector because care in the private sector is.
We can't hear you, Inayat.
Hello.
I think
by the women themselves.
Inayat, I'm sorry, we
Hi.
just the last 1 minute of what you said because your screen just froze.
Oh, sorry. So should I go through the slide again? All right. So as I was saying that in Shimla there is there's a municipal corporation, but the role of the municipal corporation in ensuring health and well-being of waste workers is absent. So there is a corporation health officer that is placed within the municipal corporation, but the role of the CHO is to ensure hygiene and public health safety of the city, and not of the waste workers themselves. The focus always tends to be on occupational health. There is, a greater focus on curative care as opposed to preventive and promotive care, which, as you can see by the lives and the working conditions of the waste workers. I mean, preventive and promotive care is very, very necessary for their well-being, but there is an absence of that. In India and also in Himachal Pradesh, we have a three-tier health system. So you have primary healthcare facilities, which are supposed to be located closer to where people live. Then there are secondary healthcare facilities and tertiary healthcare facilities. Shimla, being the capital city of the state of Himachal Pradesh, has a lot of tertiary care facilities, and the primary health architecture in the city of Shimla, like in a lot of urban areas, is absent. And this creates an over reliance on on the tertiary care facilities in the city. The public health system of India is overburdened, and the same is the case in Himachal Pradesh and in Shimla. And so accessing care in a public hospital involves, it'll take up pretty much your whole day. And it involves giving up the day of work and your daily wage for accessing public health care. And that becomes a disincentive for people to access public healthcare facilities and pushes them towards private care. Um, there are also differences as far as gender is concerned. So the health care needs and the well-being needs of women in the family are often deprioritized. As one of the waste workers from Shimla was recounting the experience of accessing healthcare within her family, when her husband had healthcare problems and needed care, they accessed care in a private health facility for which they had to make significant out-of-pocket expenditure. But when it came to her own aches and pains, she was hesitant to one, access care in a private health facility because it's expensive, and she was she did not want to go to a public health facility because it required giving up daily wage. And this we find is substantiated even in literature, where the healthcare needs of women waste workers and women in general are deprioritized within the family. um, and then, like I said, in terms of accessing care, even in public health facilities, people end up relying on their personal networks or networks within the waste workers collective, and there is no formal mechanism by the municipal health corporation to ensure that people are able to access healthcare. The society of which the waste workers are a part, which is essentially an outsourcing of responsibilities by the municipal corporation, is called the Shimla Environment Heritage Conservation and Beautification Society. So as you can see, just in the name itself, there is recognition of the role that waste workers play in ensuring environmental conservation. But at the same time, what is the support that they require is something which is missing as far as the structures of the municipal corporation are concerned. Coming to COVID-19, again, I think COVID-19 highlighted some of the precarities that people already face, and the overall outlook of the state actors towards the health and well-being of people. So there was provision of personal protective equipment, but again, in terms of quality and quantity, this was lacking. As one of the waste workers was highlighting, they were provided with one PPE kit, which they were expected to wash in their house and reuse every day. And there was no training or proper provision for donning and doffing of the PPEs, which, as we've seen during COVID, there have been various guidelines about. But this, despite recognition of waste pickers as frontline workers during COVID, these services were not extended to them. Um, and also, when people are washing the PPE in their own houses, there is significant risk that they are putting their own family members at. But at the same time, there was no support that was provided for ensuring, well-being and safety of the family members of the waste pickers. Regarding testing, again, there were no proper screening services that were being provided to the waste workers who were going door to door collecting waste, also from houses where people were COVID positive. And there was no testing, screening, and ensuring that waste workers were actually protected against COVID. We find a similar attitude even during general times, where there is no data that is available, and no data that the corporation has, for example, say on maternal care. So how many waste workers were pregnant? Did they receive their maternity benefits, etc.? That is something that is not institutionalized in terms of support and awareness. And there is a lot of dependency on the supervisor of the waste workers, or the networks within the waste workers collective for accessing care or for accessing any sort of social support. The waste workers in Shimla have access to health insurance, provident fund, maternity benefits. I mean, on paper, but in terms of actually ensuring that these are accessible to the people, there is very little institutional support. Can we move to the next slide?
Inayat, can I, sorry, please ask you to conclude?
Right. This is the concluding slide. So when it comes to resilience, we find that that there is resilience at the cost of withdrawal of the state's role in the lives of people. So the question really becomes that where is the state and what is its role in the lives of communities who are undertaking work that is the role of the state, that is ensuring public sanitation and hygiene. And overall, in the models of solid waste management, we find that there is a withdrawal of state welfareism, and there is a push for informalization. So even the models of waste collection, which are held up as as the gold standard, are models where where the entire waste work is informalized. We find that there is a dependence on community-based organizations and individual networks for support, whether that is for accessing social welfare and services, or for accessing healthcare, or for protecting against discrimination and violence. As Shrutika described, that waste workers tend to be from the marginalized sections of society, and they are often looked at as as criminals by the law enforcement agencies and also residents. So again, protecting against discrimination and violence is not something which is undertaken by the state. And even for alleviating any forms of distress in their life, there is a dependence on CSOs and individual networks because of the nature of informalization of their work. We during COVID, when large parts of the population were going hungry, a lot of the relief work was carried out by the CSOs, and we found that the state was again largely absent in this. And I think with this, I will conclude. Thank you.
Thank you, Shrutika and Inayat. I think it already did answer some of my questions, and which I think I'll bring back when we have our panel discussion. Largely around the fact that they could be sort of said to be the climate warriors, but their own lives and their living conditions are not a question of, are not a subject of discussion. And that's where I think my question was around just considering livelihoods alone enough, but we have to look at the precarity of lives of people themselves, which work in precarious environments. Thanks. So I think hopefully we'll have time for panel discussion. We'll go to the next speaker. The next speaker is Wafa. Wafa is going to present perspectives from Dhaka. Wafa, I'm just going to share the presentation and you can start.
Thank you, Vinod. So do I start, Vinod?
Yes, yes, Wafa, you can go ahead.
Okay. Hi, everyone. I'm Wafa from Bragg School of Public Health, and I'll be talking about some of the work that we do in Arise Bangladesh, focusing on urban marginalized people, their health and well-being, their vulnerabilities, and how these urban poor navigate through these experiences and challenges. Uh, can you go to the next slide? So to start with a short overview of Arise Bangladesh, it's led by the Bragg School of Public Health. Our work focuses on health and well-being of urban marginalized people and understanding on how to improve their accountability. So we work with the most marginalized urban poor, including extreme poor households, people with disability, elderly people, etc. Next. We work in 3 informal settlements in Dhaka. That's Kollanpur, Porabosti in north, and Dholpur and Shampur in the south. Next slide, please. So Bangladesh is one of the most densely populated countries in the world. And like other countries, urbanization in Bangladesh is inevitable. And currently around 38% of the total population, which is nearly 35 million, they live in urban areas. So it's a climate vulnerable country, and it's prone to many climate induced problems like heavy rainfall, waterlogging, increased heat. And this rapid urban growth is due to the rural urban migration. People come to urban areas to escape climate risks like river erosion and for better employment opportunities. Next. While people do start coming into urban cities, they fail to meet the increased expenses and they're left with no choice but to start living in informal settlements in these urban spaces. Currently, 1.5% of the total urban population in Bangladesh live in informal settlements, many of which are built on government empty plots or private lands. These settlements are also built on low-lying areas in most cases, making them more prone to climate risks like flooding and other calamities. In Bangladesh and in Dhaka city, around 7 million people live in these informal settlements. Next one, please. Vinod, can you change the slide? Okay, so urban informal settlements, like we all know, are dynamic in nature. And within these settlements, there is diversity among people where some are ultra poor, some are comparatively better off. There is also geographic and locational variation. While some informal settlements are stable, others have grown on areas with where there's already plans of building railways, mills, etc. Some settlements have more services, while others have fewer service providers in close proximity. And they, through many forms of uncertainties like eviction, fire, they have lack of access to basic health facilities, and many are found to be depending on informal.
Hi, Wafa, we can't hear you. We lost Wafa. Can anybody else hear Wafa? No?
No, we can't hear her.
Can't hear. Wafa, can you?
In fact, she seems to have dropped out because I can't see her at all.
Okay. I think in the interest of time, maybe we'll bring Wafa back in later. Or is she back? Can you see Indu if she's back?
No,
Okay.
can't see.
Okay. Okay, sorry about that. I think Wafa seems to be having some connectivity issues, and in the interest of time, I think we'll bring Wafa back in later when her connection repairs itself. So I think we can go with our next.
Wafa is back. Wafa is back. Yes.
Hi, I'm so sorry. I think I got
Yeah.
disconnected.
Okay, okay, Vafa. That's fine. That's fine. Sorry, Aditya. Go ahead.
Okay, can you move to the next? I don't know where I got cut off.
We're on this slide. Yes. I think you finished this
Okay,
slide.
okay, so can you move to the next one? So I'll now present the case of Kolanpur Purabosti and talk you through some of the problems that the community faces and some of the initiatives that they have taken to navigate through these challenging experiences of climate change and then COVID-19. Next slide. Hi, Vinod. Thank you. So, Kolanpur Purabosti is situated in Ward 11 of Dhaka North City Corporation. It's built on government land in 1980. The district of Bangladesh after experiencing heavy rainfall, coastal erosion, and other forms of climate calamities. So it is now home to around 15,000 people, many of whom they work as rickshaw pullers, garment worker, and other forms of daily wage work. And while these people moved here for better opportunities, they're often faced with many vulnerabilities, many of which are linked to climate change. And then these vulnerabilities have been further multiplied since the pandemic hit the country. Next slide. So, this is one of the problems that the residents of Kolanpur face on a regular basis. So, waterlogging is an inevitable problem, especially during monsoon. And one of the reasons for it is the absence of a proper drainage system. There is just one very narrow drain that has been built by one of the NGOs that services that slum in 2003. And ever since then, there has been no reconstruction, even though the population has increased. There are problems like solid waste being clogged in the drain. And while many community people have raised concerns about their drainage, there was no response from service providers or governance actors. As you can see in this picture, Kolanpur becomes flooded when there is rainfall and it causes problem in mobility. Next slide. Another problem that they face is water scarcity. So many sections in the slum have interrupted supply of water. And during this crisis, people have to go far to collect water. They collect it from their neighboring taps. And as you can see in this quote, that people have lined up since 3 a.m. in the morning to collect water. So similar to the problem of water logging, no service providers tried solving this problem, and only community-based organization members came forward. So in the next slide, we'll see a small initiative that was taken by community. Can you move to the next slide? So, so what the community in Kolanpur did is they collected funds and they contracted the service to plumbers to fix their water line. And now they have, since July, I think, last year, they have good uninterrupted water. So what one of our male co-researchers from Kolanpur said is that if they report it to WASA, who's the government as a service provider for water, so they need to submit an application, they have a long waiting time, and often maybe these applications are not prioritized. So instead of waiting for the response from WASA, what they did is they collected their own funding and then they fixed their own lines. Next, I'll take you through some initiatives that were taken during COVID by the community. So next slide. During the initial phase of the pandemic, people struggled with the message of physical distancing. In informal settlements, around 30 to 40 people, they share communal spaces like toilets, cooking space. So maintaining distance in these spaces were not an option. So what did the community do? Community leaders, landlords, and CBO members, they took initiatives to clean the toilet after every use. They limited the waiting line outside the toilet, and they also restricted outsiders from visiting these communal spaces. Community residents themselves got together, they discussed among one another, they talked about limiting interactions at these communal spaces. They talked about limiting kitchen use to one or two people at a time. And these helped them maintain as much social or physical distance as they could. Next slide. So another one was the unavailability of hand washing facilities. So many landlords and community-based organizations, they got together, they set up temporary hand washing stations. Then there were many youth volunteers who, from their own local volunteer club, they managed some funds, they distributed soaps to community spaces like mosques, like playgrounds, like school grounds. So these help people practice measures like hand washing. Next slide. Another problem that they faced was the mismanagement and often unfair or uneven distribution of relief or aid that came from different government and private institutions. So one of the systems that were set in place was that whenever any relief came into the community-based organizations, together with community leaders, they set up their own systems whereby they prepared lists to keep track of who received aid so that when the next one comes, someone who did not receive in the first drive would get priority. Community residents also shared their aids with their neighbors who hadn't received it. So these were some of the things that they did during COVID to survive. Next slide. So this would be my concluding slide. And then all of these initiatives or these survival mechanisms of the urban poor, they're often seen as resilient behavior. We call this their resilience, and it is often glorified or romanticized, like Vinod said. And while resilience is important because it gives people the strength that they need to overcome a crisis, and while resilient people can tap into, say, their strengths and support to overcome the challenges, we need to acknowledge that this comes from a point of compromise or from a point of reduced resources. And when we tend to glorify these resilient behavior, it also somewhat overshadows the accountability of duty bearers, many of whom do not have a comprehensive understanding on marginalized communities, and then plans and services that are provided to these communities. They're sporadic in nature, and the response by the duty bearers are not sustainable in many instances, often making these urban poors more dependent on the support. So it's important that we capture these learnings, these community initiatives, and institutionalize them, like Vinod said. And these resilient behaviors, they need to be acknowledged, they need to be understood and supported. And by support, I mean maybe just through some simple, say, you provide them with some information that they need to, take up these initiatives and strengthen them. So I don't know if I answered any of the questions that were posed at the panel as opposed to raising more, but we need to be careful and when we glorify or romanticize resilience. And with that, I would end my discussion. Thank you.
Thank you, Wafa. That was great. I think the sheer absence of formal processes that could be extended, that should be extended to everybody universally, is what results into people finding ways, because you need to survive, right? How are you going to survive without what? How are you going to survive without sanitation? And that the mechanisms that people develop are mere survival strategies. And it is important to acknowledge not necessarily the strategy that they use, but the need because of which the strategy gets developed, and address those. And acknowledging that should be a part of adaptation plan. So I think you did answer some of my questions, and I think we'll have more. Hopefully, we will have time for discussion. Okay, so we have an exciting next presentation from all the way from APU, Asim Premji University. Aditya, all yours.
Thank you. Thank you very much, Vinod. Hi, everyone. I'm very happy to be here. So a little bit about me. I work in the broad area of environment and health. And as part of this, I worked on climate change and health specifically, and have also had some experience on conducting health vulnerability assessments in rural areas. My experience with urban areas is a bit less. And I think one of the main experiences I had was this particular report, which Vinod referred to. It's called Healthcare Equity in Urban India. Few of us at the department here, we wrote it last year. So that definitely gave me a much deeper insight into the situation of urban health. And so I'll draw from both of these sets of experiences over the next 15 minutes or so. So when first look at health disparities in urban areas in India, and as others have mentioned, the reason we need to look at health disparities in urban India is because it is climate change vulnerability and health vulnerability in general are not divorced from each other. They are very much.
We lost Aditya now.
Hello? Can you not hear me? Hello?
Yes,
I
we
can.
hear you. We can hear
Okay.
you.
I'll continue then. All right.
Yes.
Okay. So it's very much important to learn about general health vulnerability, and climate change is, you can say, a multiplier of existing problems. So hence it is important to understand about the health status and health disparities as they exist. So firstly, and I won't go into details because they have already been covered by some of the other speakers, the health vulnerability in urban areas are arising from multiple factors, interacting factors and dynamic factors, such as living conditions, including those who are homeless, those living in informal settlements, the precarious and hazardous occupations, such as what we heard from our other speakers, and also the social exclusion from services. About this, I'll speak a little bit more maybe on the next slide. But before that, a little bit about health status and health disparities. So one important phenomenon that we noticed from the secondary data over the last several years is that the prevalence of non-communicable diseases such as diabetes and hypertension are all increasing quite rapidly in urban areas and in rural areas as well, but more rapidly in urban areas. And it is important to see that the prevalence of non-communicable diseases is actually comparable between the poorer and richer sections of the society. So often it is considered that, especially in the South Asian context, it is the wealthy who are affected by non-communicable diseases. But we see that the prevalences are actually quite comparable, even between the poorest and the richest sections of the population. This is important because these kinds of conditions, they are quite expensive to manage. They require lifelong treatment, and definitely these can lead to much more serious conditions such as a heart disease and kidney damage, all of which can really add a lot of burden to the household. So definitely this is one important factor. And those who have these sorts of comorbidities are automatically more vulnerable and more sensitive to the impacts of climate change as well. So in general, this is already a problem, and this could be even worse in the context of climate change. We also see that, especially here, the statistics on this table is looking at the prevalence of stunting, which is one of the indicators of child undernutrition, so children under the age of 5. We see that in several states in India, the prevalence of urban stunting is actually increasing over the recent past. And this is definitely a matter of major concern. Two important things to keep in mind while looking at this data is that, one, this data was collected before COVID-19. Most of this data was collected before COVID-19 happened, and the direction was already worsening. And we know that in the context of COVID-19, the most vulnerable groups also had challenges with accessing food and water, especially during the initial part of the pandemic. So I can only imagine that these statistics have got worse over time. And in addition, these kinds of data are probably worsening in urban areas because some of the most vulnerable populations from rural areas are migrating into urban areas. And therefore, these are all matter of great concern when we talk about urban health. Now, all of this in the context of a worsening air quality in urban areas, increased exposure to heat, as was mentioned by some of our colleagues, loss of green cover, loss of water bodies, occupation of these water bodies by infrastructure, and also by vulnerable communities occasionally, and rising costs in urban areas, all of which contribute to worsening of health vulnerabilities. If we were to look a little bit more closely about access to healthcare in urban areas, we see that at one level, there is no clear health system per se in urban areas. There are a multiplicity of providers, and these providers are not adequately speaking to each other, not adequately coordinating with each other. And for some areas have got a sort of an oversupply of healthcare, whereas some areas are underserved. In addition to this, we see that even according to the government's own norms, the number of health centers are inadequate in most urban areas in India. In some areas, the shortfall is as high as more than 60% or 80%, as you can see from the areas that are more yellowish or brownish and reddish in the map. There are several states in India that have inadequate number of healthcare facilities. These are public healthcare facilities that I'm talking about. Again, as one of the other speakers has mentioned, many people from vulnerable communities are not keen on accessing public healthcare facilities because they have experienced a lack of respect that is given to these households. And because of this, and also because of general lack of quality and comprehensiveness of services, they are pushed towards accessing healthcare in private services. And private services, of course, they are available and they are spread all over urban areas, but they definitely come at a cost. We see that most people are accessing in urban areas are accessing private healthcare facilities. And when you access private healthcare facilities, we see that the cost is many fold higher than when it is when we access government health facilities. So definitely cost is a prohibitive factor, and becoming a prohibitive factor, it either creates challenges, financial challenges for the household, or people in the household choose to delay accessing care. And this was also noticed, and there's a gendered aspect to this delay in accessing care. Some other literature also showed us that, especially women with non-communicable diseases, those who are over 50 years of age or elderly age group, they are the ones who get the least amount of care, though they're having non-communicable disease such as diabetes. And this is worsening their health vulnerability in general, and also making them more susceptible to the changing climate as well. Very briefly about health vulnerability assessments in urban area. So this is just from a report that was released last year by the Council for Energy, Environment and Water, which is based in New Delhi. So they did a district level assessment, and there were just two small mentions about urban areas in the context of urban flooding and urban heat island effect. It was just in passing. And generally, if you look at how they have tried to understand vulnerability in districts, they have just chosen very few indicators. And you see that the social indicators of exposure, of sensitivity, and adaptive capacity are missing from this conceptualization of vulnerability. And there are various reasons why we need to very closely look at the social and the health situation of communities to understand about vulnerability, whether to climate change or whether to poor health outcomes in general. And for that, I'll give you an example from what we did in a rural area. So here I had the opportunity to just conduct a health vulnerability assessment at the level of just one village or a few villages. And some of the things that we found out, because we paid this close attention, we could not have got if we looked at it just from the level of a district. So here we spoke to workers, and we clearly saw that workers who were working on as laborers in other people's farms or in some sort of plantations, they were not able to take a break during the hottest parts of the day, even during summer. They did not have a place to rest in their workplace. And this was not the case with people who own their own farms, for example, who are able to regulate their work timings. Secondly, if you see the picture here on the left, we see that many of these households have recently adopted tin roofs. Okay, and tin roofs we see are quite ubiquitous in urban poor settlements as well. So here we thought, okay, this is definitely not a good idea, because during the hot part of the day, the elderly and the children who are often at home, they were sitting outside their houses because it's not possible to sit inside the houses in the hottest parts of the day because the tin roof gets so hot. But they said that it is still worthwhile having the tin roofs because during the rainy season, it helps them as compared to what kind of roofs they had earlier, which was straw and tiled roofs. they definitely said that this was definitely a better situation to have a tin roof, which was protecting them from severe rains during the rainy season. So to understand some of these phenomena, going closer and interacting with the local communities definitely helped quite a lot. Very briefly about the National Program for Climate Change and Human Health. So this was actually put out by the government of India in 2019. And the first objective, for example, was to create awareness in the general population and the vulnerable community. But based on everything we have heard now, we see that awareness itself is not going to go very far with vulnerable communities who have so much lack of access to resources. They may not be able to act on this awareness, and it may be quite irrelevant to these vulnerable communities. Secondly, it was to strengthen the capacity of healthcare system to reduce illness and disease due to variability in climate. Now, what capacity of healthcare system are we talking about when there is so much inadequate healthcare in the first place? So the public health systems are already quite weak and are somehow getting weaker with time. So can we talk about capacitating them for climate change? We should even be talking about general strengthening of public health systems. And only in that context can we talk about enhancing their ability to deal with climate variability and those related illnesses. Then they also talk about conducting vulnerability assessments, which definitely is a good idea. The need to work with other missions and other sectors, which is definitely important. We'll see that as we go along. And to strengthen research capacity. I'll not talk about that. So because COVID happened in 2020, I think most of the work of the health departments have been diverted towards COVID. But even in this context, some trainings related to climate change and health and impact of air pollution on health was given to health workers in many states in India. I think mostly in rural areas, but this is at least something that they've been able to start despite the COVID-related pandemic, which is, I think, a small positive step. I'll not talk about this. So one other nice, interesting experience we had was we interviewed doctors and healthcare providers after floods that had occurred in Kerala in 2018. Some of you may be aware that there were floods in Kerala in 2018, which badly affected several communities and also healthcare centers. So it was interesting to hear the healthcare providers talk about the need to be proactive to address some of these situations. They talked about some of the larger determinants that need to be taken care of in terms of not encroaching, for example, water bodies, checking illegal mining activities, preventing deforestation, maintenance of roads, as general interventions that need to be done, which cannot be done by the health system, but rather the other sectors that need to really play a role to reduce the vulnerability and increase the resilience of the local communities. And also the need for hospitals to reorganize themselves and to become more resilient to changing climate. So for example, the need for shifting certain services from the ground floor to the first floor, for instance, maybe shifting the hospital altogether if necessary, different approaches for backup for electricity, maintenances of records and medicines. So very interesting insights on all of those aspects, besides the broader interventions such as emergency warning systems. So they have done they have learned from these experiences, and they are making some changes in the primary health centers in some of those areas in Kerala. But just to conclude quite quickly and not take more time than was awarded to me. So overall, when we think about urban health resilience, some of the things that come to mind are that we need to consider all of these aspects of urbanization. There is in-migration, there is increasing number of vulnerable communities in urban areas. There is a general phenomenon of aging happening in urban areas. Comorbidities, including non-communicable diseases, are being experienced both by the poorest and the other sections of the urban population. Socioeconomic challenges, infrastructural and ecological aspects, is occupying low-lying areas and water bodies, and reducing the green cover in urban areas. All of these things need to be taken care of if we are talking about urban health resilience. A better understanding and involvement of urban vulnerable communities is one of the other things that emerged as an important point when we were writing our urban health report. We saw that there were several small examples of this sort of involvement which community-based organizations such as SPARC have been facilitating, for example. And this definitely had some impact in improving access to services, improving the relevance of services to urban, poor and vulnerable communities. So this is definitely important. And the role of the community-based health workers also became important in this context. A general improvement that is needed in strengthening public health and healthcare, access to healthcare, uh, irrespective of the context of climate change. This is definitely needed. Climate change is just one more reason why we need to strengthen public health and access to healthcare in India and elsewhere in South Asia. But climate change is not the only reason. There are many other important reasons. A general additional value that is given to health when we think about developmental planning. Should we plan without considering health, especially health of the most marginalized populations? I think we should be thinking about health and health equity. And we should learn from experiences just as they've done in Kerala with the example of the floods there. Even in Ahmedabad, they've done some interesting interventions in the context of heat vulnerability. Learn from these experiences, keep equity in mind and be proactive. I think these are some of the important messages that we were able to receive from the work that I've done. Thank you.
Thank you. That was really great, Aditya. I think the next presentation was going to be actually sort of a continuation of your last slide, where you said that it is not looking at one thing, but it is an intersection of many different things that impacts people. So I think hopefully we'll have some 10 minutes for panel discussion later. I'm just going to quickly present what Smriti was going to present, just to make a point that about what a special planning area is. So when we were discussing on the subject of what we will present in what this panel will present and discuss on, the thing that came to all our minds is that living in urban areas, especially for those living informally, the intersection of climate change with many different aspects is very important to consider when we look at building resilience and creating plans that are inclusive and adaptive, etc. So one example of something that is already happening in some part of the world is an example of Mukuru special planning area. Mukuru is a place it's a large slum in Nairobi. Unfortunately, we couldn't get anybody from Kenya to participate. It's too early there. But so largely what it says is, so this is like an aerial view of the slum. And you can see a lot of tin sort of structures or informally laid out. This is the kind of habitat that people are living in. Fires is one common hazard that they keep seeing all the time. These are the pathways to navigate through the slum housing. But what necessarily this Mukuru SPA means, special planning is when the government declares a particular slum as a large informal settlement as special planning. So it means that you look at all different aspects of planning. You challenge the norms of planning in terms of what the conditions, local conditions are. For example, mostly 90%, I think, I don't know the exact number, but I think 90%, close to 90% of people living in this slum in Mukuru are renters. So if you have a policy, if you have a development plan that says housing without acknowledging the fact that 90% of them are renters, and there's going to be this tension between the house owners and the renters saying who gets access to what if you redevelop it, and that what do you do with people who are renters, who may not necessarily have all the documents to prove that they are legitimate citizens of your city. You have an issue, so the plan will not work. If you do not consider the kind of local transport systems that people need in order to, and that's what they've been using, and create roads that are meant for large vehicles to pass through, which the people cannot afford, then you end up nowhere. If you create a development plan that looks at utilizing the land to its best value and putting people into tall buildings, the people are not going to be able to afford the maintenance and pay for the water to be pumped up, etc. So if you don't look at the set of health requirements of the whole set of population based on what the population actually requires versus what the urban planning norms are, you're not going to end up improving people's lives automatically. So it's a combination of many different. I will not go through all these slides as. So it is a combination of many different sectoral plans that look at different sectors. There are 7 sectoral plans, there were budgets for it, etc. But largely it looks at merging the planning norms that are normally advocated as planning norms that urban development needs to use in order to improve the lives of people within the urban area, challenge them and modify them in order to meet the needs of the people there. So the idea of keeping people central in any of the plans, in this case, development plans, in some other case will be adaptation plan, by keeping people central, meaning we do acknowledge the aspirations and the needs of people and develop plans that can address those rather than developing plans which need to satisfy a particular set of norms, and some of those norms need to be challenged, and it's time that we challenge. So I think I'm going to end this presentation quickly because I had only allotted 5 minutes for me to speak on that. So that we have some at least 10 minutes for the panel discussion to happen. But largely looking at when you have urban development plans, you have adaptation plans, and if it does not acknowledge that there are some existing set of policy inadequacies that do keep people vulnerable, have been keeping people vulnerable to many things. And if those are not addressed, and if there are no policy initiatives that try to address them, anything that you talk about, any subject that you talk about is a sort of a nice subject to discuss on, but it will still not address the real problem that we have on hand. So one question that I want to ask all the panelists is that in the work that you have done, and all of you have presented about the, some of the very basic issues that people don't even have access to. So the question of looking at climate change and the vulnerabilities faced due to climate change and including them within the whole adaptation plan. Do you feel that there are many other policy issues that we already have that need to be looked at either separately, importantly, and more urgently, because there's an impending disaster waiting to happen in the form of, it's already happening, but it's going to become worse and worse as we in the coming years. Do you see that there is an urgent need to look at those, address them, and what would that be in that case? Or you see that now there is just no time and that needs to be integrated within the entire urban development plans or adaptation plans or public health policy plans, etc. Because I think one of the issues that we have in largely in the global south is the piecemeal fashion in which issues get addressed, and because the issues intersect with each other, and only institutions like the government institutions actually have the capacity and the resources to do that. And when they shy away from doing it in a very integrated manner, what is it that what is the message that we have to give there? And that's the message. I think the last concluding points by all of us is what we would put as points for the Gobeshona to take to the COP27 on behalf of what we would like to say. So I think I'll go in the reverse order maybe. So we will start with Aditya.
Okay. Don't really know what I can say. So, see, at some level, it might be very tempting to just look at this very sectorally, saying that, yes, let's just focus maybe on strengthening access to healthcare, for example. It seems somehow it seems a little bit more manageable. But at the end of the day, we see that the conditions that are leading to poor health are so many. By just addressing access to healthcare, we will just be touching a very, very small part. And so the health vulnerability experienced by urban poor communities, definitely needs a very integrated sort of an approach. Where this is happening adequately, as an example, in South Asia, for example, I don't know if there is any such example that we can look at where adequately people have been working, in coordination, various departments coming together to reduce health vulnerability. The role of all other sectors, including housing, urban development, water and sanitation. We don't unfortunately see these sorts of things happening, but they definitely need to happen. I don't think we can continue working as separate departments in siloed fashions and expect that there can be great improvements. And at some level, this is related to not putting people at the center. It is related to lack of accountability and corruption. There are many of these factors, underlying factors, that are creating these challenges, and we have to take them face on if we have to address some of these challenges.
Thanks. Thank you. Yes, it's a risky business, but I think that's the only way out. I think Wafa, are you still on or have you left? I think Wafa said she had to go. She had to be in some other event, and so she's unfortunately not with us. So, but we will insert in later if she has comments. Shrutika and Inayat. Inayat, would you like to go next in the alphabetical order?
I think Shrutika can go first, and then I'll add in.
Right, Vinod. Thanks for your question. So, Inayat and I were just discussing this on the sidelines, and what we figured is that I think in the context that we're working in, especially for waste pickers in the informal sector, there was a recent ILO report that we were looking at, which estimated that about 4 million waste pickers live and work in India. So that's about, I think, 1/3 of the total population of waste pickers across the globe. So, I mean, looking at that scale, I think we have a much larger problem in terms of just identifying and recognizing them as citizens of this country, as residents of this country, which are entitled to basic rights and entitlements. Here, we're not even looking at sectoral level policies, as I think Aditya was taking an example of, in terms of healthcare. We're not even looking at that. We're literally just trying to see whether at least the state should make the effort to kind of recognize that there is this volume of workforce that we have in this country, which don't even have the basic rights and entitlements. And I think then everything else can come in a little later. But of course, we also understand that climate change is a very real issue and it is impending. And we don't actually have the time to go through things in a sequential or a chronological manner. We don't have that kind of time. But what we're saying is that I think the burden of dealing with climate change issues and trying to adapt can possibly be more redirected towards people who come from much more stable socioeconomic backgrounds. For example, the middle class or the rich. So, for example, I think single-use plastics actually have no relevance for waste pickers because they're not able to sell or really gain anything out of selling single-use plastics. So why not go after corporations that are actually producing this item in the first place? Why are we focusing so much on the way that it's being disposed and stuff? But that's obviously, we're cognizant of the fact that corporations and the state have such an intimate relationship, and it's very difficult to go there. So I think from the context that we're working at, I think our focus would be to kind of push the state to at least try and recognize the work that the waste pickers really do, and at least secure the basic necessities that are required for them to actually just live and work in a country like ours. So I'll just hand over to Inayat to add to what I had to say. Thank you.
Thanks, Shrutika. I think adding to that, we know as health researchers that impacts on social determinants of health impact overall well-being of people, and I think over there health systems do have a very strong role to play. I think unfortunately we look at health as something that's just curative, medical, and disease focused, but the mandate of the health system is much wider than that. We've seen during the COVID pandemic that the capacity of the health systems to absorb disasters is very low. We also have a multi-sectoral action plan at the national level pushed by the Ministry of Health that encourages the health sector to collaborate with other sectors to address social determinants of health and bring in the well-being perspective into health. We also have a national action plan on climate change in India. The funny thing is that the action plan says that the stress is on maintaining a high growth rate for increasing living standards and reducing people's vulnerability to the impacts of climate change. But I think, and I mean, they've listed out these 8 missions in the action plan, but nowhere at all is the health system mentioned. So I think, we do have policies that exist that provide, sort of architecture for the health system to look beyond just medical curative care and look at some of these more well-being aspects. And I think that is where integration of climate change is required and could be brought in through this multi-sectoral action implementation. I'll end here.
Thank you. That was that was very important. And I think what is coming out very strongly from what everybody is also presenting is that one is that there is a crisscross kind of interaction of many different existing issues, issues that already existed, issues that are being exacerbated because of climate change, issues where the disparities are becoming much and more acute because to some extent climate change is driving it, but also the other forces of global capitalism and the kind of economic policies that we have, etc. And there is a danger in saying that you integrate all of them and you look at them in a very piecemeal fashion. But there is also a need to kind of have those, those linkages being very clear, because otherwise you end up in a situation like what Inayat was saying, is that some things like basic public health actually get left out. There is Celine who has raised her hand. Celine, would you like to say something?
Only if there is time.
Oh, you've already typed.
So I have a question, more than a question, a comment, Vinod, on your very insightful remark of, community survival strategies are determined as resilience, and we have to be careful about that. And for me, I feel the line being on the front lines is very clear. It's when you're empowered with those skill sets or capacities, and when you feel disempowered, right? So one cannot have all this conversation. By the way, all of you all were brilliant. I was so impressed with the professionalism and how you all gave all your information, and yet so simply. One cannot ignore the politics, even among people like us who intervene in the lives of poor people. And so, while we are talking about the system and the mega structure and the big structure and the government and, those bad guys, I feel we cannot not look at ourselves and how we interfere or, stop or disempower poor communities when we engage with them as professionals. So for me, that is a beginning point, and I always like to keep that as the litmus test, because I feel that line is very thin when we feel, we have the answers, or we feel development has to go in a particular way, or we feel, planning has to be in a particular way, because everything around us is completely arbitrary. So when we talk about the Mukuru planning, we also know there's a huge eviction in Mukuru, right? So all the work done, what does it mean for poor communities? Ultimately, they have to lead with their governments. We'll come in as planners and leave and go. So these are the questions for me that ultimately, as practitioners and people on the front line, they have to deal with. And, people like you all with all your knowledge and expertise, very important to be allies to that process and be in tune with that process without suffocating it. On that note, I'll stop.
Yes, that's a very important reminder. I think all of us, especially in the research world or in the action research world, follow within our ethics and keep questioning our own, position that we take about certain things and that litmus test that you spoke about, is is this what the communities are saying? Is this what the communities want? And not something that we are imposing upon as the knowledge that we have. And that's exactly what the special planning kind of says, is that you have urban planning norms, but that may not work for people. So what is it that the people need? And what is it that what needs to be done for people? And we have examples like that. And we completely agree with you that we sit at the center of all of this, and there is this danger of us kind of moving on the other side, right? So thanks for that. I think we are out of time, but Indu has her hand up. Indu, do you want to go next? And
yeah, just a very quick thanks and acknowledgement. As Celine said, that it was a really brilliant presentation by everybody. And what resonated most with me were just a couple of things where, as Dr. Pradhan said, that when the governments plan, they plan at the macro level. But when you go to the ground, you see things at the micro level, and you see the various things that are actually in play, rather than the, when you actually go deep into things and look at the micro level. And the second thing that resonates very strongly with me is that normally at the micro level, all the survival mechanisms of the poor, whether rural or urban, especially in the urban, is taken as resilience. It is a coping mechanism, it is a survival mechanism, and we have to start looking beyond that. When we talk to people, when we look at them, we just can't take these survival mechanisms for granted that the communities can deal with this, they can handle this. So on that note, I really thank all the panelists, and I'm sorry we have a very meager audience today. There was a little bit of confusion about the links at the last minute. So we couldn't reshare the correct link. The earlier ones, I think a couple of people told me they are saying that they are invalid. So I'm sorry for the meager audience, but your presentations were really, really great. I'm happy that I could join. Thank you.
thanks, Indu. Yes, and we also have a low audience because I think a lot of people from Arise are actually based in time zones. This is too early for them, and they'll be looking forward to listen to the recording at a later point of time. And thank you, all of you, for coming.